Welcome to my last lecture on who are first responders and what do they do. This is lecture 11,
11.
a great course series called When Everything Fails, How to Survive Anything.
Just as there are different levels of emergency medical response, there are different levels of hospital emergency department.
But wherever possible, I advise my friends and family to go to a university teaching hospital rather than their local hospital.
Professionally, you may be more likely to hear emergency department or ED than emergency room.
I worked as a registered nurse in a level 1 Canadian teaching hospital, the biggest one in Canada, between 1989 and 2021. So did my wonderful life partner, Kitty. In 2000, I moved to a different hospital in the downtown core that was actually a level 1 hospital as well. This one specialists in heart-lung transplants, and I spent 4 happy years working there on nights. Before returning to my first love as a nurse, which has always been trauma.
There are 5 levels of EDs, or trauma centers, from level 1 to level 5. Rankings are based on resources available and services provided. Level 5 is the lowest, but at a minimum has emergency physicians and nurses and can provide critical stabilizing care before transferring to other hospitals.
In any hospital, you won't get Arnold Schwarzenegger looking after you, but you will get real superheroes like Kitty looking after you, and you should be really happy and grateful that there are superheroes out there that work in hospitals to help you.
Level 1 is the highest, with quick access to a variety of specialty care teams and what the American Trauma Society describes, and this is a quote, as total care for every aspect of injury, from prevention through rehabilitation.
This all sounds great, but women are still giving birth flat on their backs. Modern healthcare is nowhere near as advanced as people like to pretend it is. Typified by dramatic helicopter arrivals on the roof, to dashing into the emergency trauma room, to go into the operating room or the ICU for care, that is how we perceive modern healthcare in emergency departments. The truth is somewhat different. The majority of people in emergency departments are drunk, intoxicated and angry individuals. And that's just the staff.
Like so many other areas of emergency response, the field of emergency medicine has developed over time.
The only things we've become good at since the 1960s is actually delaying death. We haven't become very good at preventing death. Death will happen. 100% mortality is what we are still experiencing. Death has not been beaten. You cannot fight death. What we can do is delay it in certain circumstances. It costs a huge amount of money and resources, but we've become fairly good at that. But in the level 1 trauma ICU I used to work in, and Kitty worked until she retired last year, approximately 30% of all patients admitted to our unit died there. Of the surviving 60% or so, 50% of them would die in the hospital before they got to go home. Mortality is a fact of human existence. You cannot fight or avoid death. How we live and how we experience life, that's the key things I learned from decades and decades in an ICU where a lot of people died.
Residencies for emergency medicine to provide advanced training, just as other medical specialties require after the completion of medical school, only date to 1970.
First intensive care unit in the world was 1953 in a place called Copenhagen, which is in Europe, and that was because of polio. They had a lot of ventilators for the kids and iron lungs, and they needed specialized care and treatment. The first ICU in America was 1955. All of the trappings of modern life is very, very new, and socially and mentally, and in fact spiritually, humanity has not adjusted to the level of technology we're currently experiencing.
And even after that time, it was not uncommon for EDs to be staffed by physicians with specialties in other areas.
Okay, I'm so sick of this. Nurses and then respiratory therapists and other people designed, operated hospitals, ICUs and emergency departments. Medical involvement by doctors was minimal.
Today, there are many emergency medicine residencies throughout the country, and physicians, nurses, and other ED staff are specially prepared for the unique demands that their unit requires.
Healthcare in Canada has to be very, very flexible because we get things like roving bear populations walking through our hospitals on a regular basis. In truth, though, I have dealt in reality with raccoons, squirrels, and bats in the hospital. You have to be flexible when you're dealing with human beings. You have to be human when you deal with human beings.
To tie our discussions together in this session, I'd like to offer several observations.
Please do. Do you think he's going to talk about funding of all of this?
Response from multiple agencies with many resources is often required. Fortunately, agencies regularly train and exercise together and are prepared to do so.
Well, sounds great, eh? I can tell you, in Canada, this is very, very uncommon. Almost all of our hospitals are publicly funded, but privately run by trusts. The communication and the movement of staff between these private trusts is minimal, and that harms the health of every Canadian.
Over time, each of the fields we've discussed, dispatching, law enforcement, the fire service, emergency medical care and transport, and hospital emergency departments, has become more specialized.
What we didn't get rid of Nightingale wards. When I started nursing in 1984, for the first 2 years I actually worked on Nightingale wards. And I can tell you that on a Nightingale ward, the focus is nursing care. Nobody on a Nightingale ward falls out of bed unobserved. Nobody in a Nightingale ward screamed out loud in pain and was ignored. Now, of course, the doctors and administrators have took over, and technology and improvements in efficiency have become the major thing. Society wants to have more MRIs, not more nurses to wash people. We've got our priorities badly wrong, and this makes healthcare very inflexible.
More professionalized, and with higher training standards.
Got another pro tip for you. If one of your loved ones is in hospital, if you can, stay with them and ask questions. Whoever walks in the room and you don't know who it is, say, "Hi, who are you?" Be polite, but who are they and why are they there? Find that out before they start doing. Make a point of learning and doing, feeding, washing, turning, bathing, helping. The nurses are not your servants. They're not your patient's servants. You are there to increase the amount of nursing care that person can get and to protect them from a healthcare system. And it's mostly run by people who are learning how to do the job. But how much disrespect does the hospital show its nurses? After 2 years of COVID-19, which is a virus that's respiratory, that requires a lot of nursing care, required a lot of nurses to take risks and do things differently for 2 years in very difficult situations, they gave them this. They gave them forceps. Forceps are a tool, not a gift. And these forceps are dangerous. They don't even have a rubber tip on them. It shows several things. It shows that after 2 years of stress, the nurses in that hospital were disrespected by the administrative staff. It shows that the administrative staff don't understand what would make a nurse smile or feel appreciated at the end of their shift after 2 very, very stressful years. And it shows that they can just waste money on buying junk. Kitty got these, she didn't want to get it, but I insisted she did. Anyway, when she got them, what I did was I put them in one of my emergency packs because, to be frank with you, they're an SHCF item, not really a thank you for working hard through COVID-19 for 2 years.
When we think about disaster preparations, it's important to know what local resources are available and what their capabilities are. To return to dispatchers at PSAPs, this is one area where their skills shine, knowing exactly what is available in a jurisdiction and ensuring that the right resources are sent to the right location to facilitate the best possible response.
So why are they paid peanuts? They work alone or in pairs, and sometimes in the huge centres they may have a mobile supervisor. But these people's decisions that they're making are actually based on statistics and efficiency, but a lot of it is in how they interpret that stuff and what numbers they plug in and what they decide to send to the scene. Their decisions literally kill people or keep them from dying.
Realize that, unfortunately, there will always be the next incident that requires a response.
Costing the Canadian taxpayers, and more specifically the Ontario taxpayers, over $1 billion Canadian dollars a year, Sunnybrook Healthcare Centre in Toronto actually focuses on things like this. Strange, but they have a registered nurse shortage. They also have an RT shortage, but nobody ever talks about the RTs, respiratory therapists. It's because it's been allowed to become a Monday through Friday business hours business. And it's not a business, it's human response to healthcare. By focusing on efficiency, targets, data that's often not real because it was just plugged in by people who were too busy to put it in, or plugged in by people who had the time to put it in to make their unit look worse than other units. By focusing on stuff that's not real but imaginary to get control, what they've done was they've pushed nurses to the periphery and people have quit. I mentioned degree nurse in Ontario. I haven't got the latest stats, but the last stats I saw about a couple of years ago or 18 months ago was that after 4 years of university full-time education and a ton of their own money, a lot less than it cost them in the States, I think it was 50% or more of these new nurses quit nursing and never ever became a nurse again. Ridiculous. And all because somebody up there thinks that a degree on entry is what you need to look after people as a professional nurse. Florence Nightingale would literally go postal on these losers.
With agencies working together, utilizing their resources and training, the first response community is poised to help the public.
Oh yeah, once they've got the lobbies and their offices and their fancy technologies up and running and looked after well, yeah, then they'll spend some money on basic health care. Bear in mind, when was the last time you heard they laid off administrators or doctors in a hospital in Canada? They lay off nurses all the time. The nurses are the ones actually doing the work.
Until next time, stay safe.
Next time, it's the first responders we never see in Lecture 12 of this When Everything Fails series from the Great Courses, How to Survive Anything. And I'm not sure if this part of the video presentation is actually that relevant to most preppers out there or people interested in emergency preparedness, but I'm going to pursue it and finish it off anyway, and I hope everybody's well. I'm recording this today on the 9th of May. It's going to be up sometime in June. I'm putting it out every Friday. I hope it goes out. I hope we're all fine, and I hope you get to enjoy this. Toodles, and thank you very much for watching. Treats! Treats! This is a Hungry Cat production 2022, closely observed by Hungry Terrier production.